Hello everybody, my name is Sarah Grünert and I'm a metabolic pediatrician from the University Children's Hospital in Freiburg in Germany, and today I would like to talk to you about the impact of glycogen storage disease type 1 on adult daily life. Although it feels really kind of awkward and wrong for me as a doctor to tell you about GSD in daily life, while each and every one of you knows much better than me what it really means to live with this disease, today I would like to share the results of a study with you that we have recently performed with the help and the great support of the German GSD patient organization. As you all know, GSD1 is the most severe form among the hepatic GSDs. The incidence is very low, about 1 in 100,000 for GSD1A, and even much lower, about 1 in 500,000 or 1 in 1 million for GSD1B. GSD1 is associated with a very high risk of hypoglycemia due to the fact that persons with GSD1 can neither break down glycogen to produce glucose, nor can they build up glucose by gluconeogenesis. GSD1 is also associated with sometimes very severe long-term complications, including kidney insufficiency, or, for example, infectious diseases or inflammatory bowel disease in GSD1B. GSD1 can be expected to be associated with a very high disease burden due to, for example, a strict diet that requires frequent meals and a strictly calculated carbohydrate intake. All patients need a good nighttime management. That means nocturnal tube feeding in some or uncooked cornstarch intake in others. Patients required regular blood glucose monitoring, and patients and their families also have to be experienced in the handling of emergency situations. All this results in a severe loss of spontaneity. The fate of patients with GSD1 has changed a lot within the last decades. In the past, especially prior to the development of effective treatments, including cornstarch therapy or GCSF for patients with GSD1B, many or most patients with GSD1 died during childhood. Others received a liver transplantation, but overall, the prognosis in the 60s and 70s was rather bad. Today, in the presence, with improved treatment, most patients really survive into adulthood without major complications. But this also brings along the fact that these patients in adolescence and adulthood have to deal with new tasks that have to be solved in this time. This means that patients with GSD have to integrate their condition and the treatment and management of the disease into activities of their daily life. This includes schooling or education, professional training and university training, but also their working situation, social activities, meeting friends, hobbies, sports, and traveling. They also have to solve several developmental tasks that are pretty much the same as in healthy peers. They have to become autonomous, they have to build romantic relationships, deal with their sexuality, think about family planning, children, and they also have to develop a certain attitude towards their disease and cope with their disease in daily life. It is well known from several studies that medical conditions, especially those that require a strict adherence to treatment recommendations or dietary restrictions, can be associated with impaired quality of life and also emotional functioning. However, only very few studies on the impact of the disease on patients' daily life for GSD patients have been performed so far, and especially data on adult patients with GSD are scarce. Previous studies have been performed, and these studies have mainly used standardized questionnaires to assess the quality of life. That means that these questionnaires have not been developed specifically for GSD. The group around David Weinstein, at that time still located in Florida, has already studied psychosocial functioning of children with GSD1A and 1B in 2008. This group investigated 31 children and also their parents, and they used different questionnaires that addressed several aspects of daily life. They addressed the quality of life, loneliness, family functioning, but also sibling relationship quality, parental distress and parenting distress, child adaptive behavior, and child emotional and behavioral functioning. In their study, the colleagues found that both types of GSD1, GSD1A and B, were associated with reduced quality of life and independent functioning. They also detected elevated levels of internalizing distress, and also parents had a higher level of stress relative to healthy peers. Another study was performed in 2014 in Italy, and this was a multi-center study including different metabolic centers. And the colleagues studied the quality of life of adult GSD patients, also with a standardized questionnaire, the SF-36, and they included 28 patients over the age of 16 years and a median age of 26.5 years. This study in adult patients also showed that patients with GSD1 may have an impaired quality of life, and especially patients with GSD type 1B, women, and those with renal complications were at risk of a poorer quality of life. What was very interesting was that GSD1 patients had lower median scores in general health perception and social functioning, but on the other side, the median scores for bodily pain and for mental health were higher, which was explained by possibly good coping strategies of these patients. What was also interesting was that the colleagues found a lower percentage of married patients with children in their cohort. Very encouraging data come from the Swiss Hepatic Glycogen Storage Disease Registry and were published in 2019. This registry includes 27 GSD1 patients from adolescence to adulthood, from 14 to 29 years. And the colleagues also assessed the quality of life by a standardized questionnaire, the SF-12. In contrast to the studies that I have mentioned before, the scores of GSD1 patients in this sample were within the normal range. So most patients really had a normal quality of life. And what I also found very encouraging is that most patients were well integrated into social and also professional life. Another very interesting study was published in 2015, and Flanagan and his colleagues studied eating attitudes, eating disorder symptoms, and also body image in GSD patients. In this study, 64 patients were included, and they ranged in age from 7 to 52 years of age, so included children and adult patients. And the colleagues found that children and adolescents and adults with GSD had a lower body esteem compared to healthy population norms. But what I find very interesting is that patients reported growing acceptance of their bodies with age, associated with less negative attitudes and behaviors in adulthood. So patients really develop coping strategies during the disease course. I would now like to tell you about our own project that has been started already some years ago by two colleagues of mine, Professor Udo Wendel from Düsseldorf and Professor Peter Burgert from Heidelberg. Professor Wendel is a metabolic pediatrician. He's already retired, but he had a very long-standing interest in the field of GSDs. And Peter Burgert is a psychological colleague who is very experienced in metabolic diseases and has just recently retired now. The aim of this study was the assessment of the impact of GSD1 on adult life. And these two colleagues decided to develop a questionnaire that was really specific for GSD and not to use a standardized questionnaire. The questionnaire that we have used addresses several aspects of daily life, including school and professional education, the job situation and working life, social life, meeting with friends, sports, but also traveling, staying abroad, the composition of the household, so if people still lived with their parents or with a partner, if they were married or not, and also the dietary management and disease monitoring. And what I find most interesting is the patient's attitude towards his or her disease. The project mainly started with a workshop that was held on the annual meeting of the German Patient Organization for GSDs, which always takes place in Duderstadt in Germany. During this workshop, the members of the patient organization and the adult patients filled in the questionnaires and later on discussed the topic of the questions in this workshop. Additional adult GSD1 patients were then recruited in the metabolic centers Freiburg and Heidelberg. And of course, this study was approved by the ethics committees of both universities. For this project, we could collect data from 34 patients with GSD1A and 1B. Of course, the majority of patients, 27, so almost 80% of patients were GSD1A patients, while only 7 GSD1B patients were included. The median age of all patients was 26 years, and the oldest patient was 54 years old. 60% were male patients and 40% were female patients. None of these patients has been liver transplanted in the past. The first topic that was addressed was the living situation or the composition of the household. And as you can see here, about 1/3 of patients still lived with either one parent or both parents, while the remainder lived either alone or with a partner, or for example, in a flat sharing community during university studies. Concerning the educational and professional status, only 3 patients reported to be unemployed, while the majority of patients either attended school or university or had a regular working life. Among the working individuals, 4 patients reported to work mainly physically, while the remainder of about 70% predominantly performed office work. Here you can see again that about half of the patients had a regular working life, while the others were still in their education, either at school, at university, or doing an apprenticeship. We also asked for autonomy in the preparation of the diet, and most patients, about 3/4 of patients, reported that they were themselves responsible for the preparation of meals and the overall dietary management. About 1/4 of patients still received help and support by the parents. This was especially true for younger patients. And a certain part of patients, about 21%, reported that they only consume self-prepared meals also at school or during the working day, while 40% and 24% also ate at a canteen or restaurant. As expected, most patients followed a dietary regimen that was defined by a certain amount of carbohydrates per hour, but that was flexible in the choice of food and the carbohydrate sources to meet the dietary requirements. 41% received continuous nocturnal feeds, either via a nasogastric tube or a PEG tube, while 44% reported to use uncooked cornstarch or glyphosate in 32%. Concerning the nocturnal management, 50% of the patients on continuous nocturnal feeds reported that they, in some situation, for example during weekends or during holidays or overnight stays outside their usual environment, they flexibly switched from their continuous nocturnal feeds to cornstarch or to glyphosate, or the other way around. 90% reported being responsible for the nocturnal dietary management on their own, while 10% still received support by the parents or partners. The majority of patients considered their nocturnal dietary management as safe. We also asked for the overall metabolic control and hypoglycemias, and 97% of patients reported to have a glucometer at home. Only 1 patient reported that she or he did not have a functional device. However, when leaving home, only the minority of patients reported that they always carried their glucometer with them, while 38% and 27% said that they only take it with them at certain times or never. In accordance with that, only 50% reported that they always check their blood glucose concentration when they suspect to be hypoglycemic. This figure shows you the number of glucose measurements for all 34 patients, and on the left-hand side you see the measurements during the day, on the right-hand side the measurements during the night. And as you can see here, during the day the management is very variable, while during the night the majority of patients does not measure glucose levels. Continuous glucose monitoring devices become more and more the standard of care, also for GSD patients, and about 3/4 of all patients reported that they either had a continuous glucose monitoring or that they had at least tested a device in the past. The majority experienced the CGM as helpful, but about 1/4 said that the CGM has not been helpful for them. We also asked for the frequency of hypoglycemic episodes in the past, and 70% reported that they had at least one diurnal hypoglycemia within the last 6 months, and thereof about 50% one per week, while daily hypoglycemias were only reported in 8% of patients. Nocturnal hypoglycemias were similarly common, with 61% of patients who had at least one hypoglycemia within the last 6 months, and of these 65% had at least one hypoglycemia per month. Episodes of severe hypoglycemia, during which patients were really dependent on external help, had occurred in about 1/5 of patients within the last 6 months. About 90% of patients were regularly followed in a metabolic outpatient clinic, and most of them were seen every 6 months or once per year. 2 patients, however, were completely lost to follow-up in a metabolic department. 81% reported that they always attend their appointments alone, while about 20% were accompanied mainly by a parent or by their partner. Interestingly, almost 50% said that they would feel more comfortable if they were accompanied during the outpatient clinic visits, while 50% expressed that they prefer to attend their medical appointments alone. The reasons for their wish of being accompanied to the outpatient clinic were diverse. What we heard was that some of them had lack of confidence, some just needed transport to the metabolic clinic. Some said out of habit because they were just used to it during their adolescence and childhood. They said they felt more comfortable and secure when they were accompanied. But also from the other side, from the side of the parents and partners or families, there was an interest in the disease of the family member, and many parents and partners were still involved in the management and treatment of the disease. Patients said they do not want to miss important information, and it was just a feeling of security when the social environment is also well informed about the disease. We were also interested in how good the communication of results was, or how the patients perceived this communication. And 80% said that they felt well informed by their metabolic center, that they regularly get their medical results, but almost 20% said that they do not feel well informed, either because the results were not explained to them by their metabolic physician, or because there was sometimes a very severe delay, and some of them only got their results when they came to the next metabolic visit. Sports and physical exercise is certainly one very important part of social and normal adult life, and 3/4 of patients reported to exercise regularly. Most patients were used to take certain measures like carbohydrate-rich snacks or maltodextrin during physical activity, and that they felt safe with these measures. But 40% reported that they did not feel fully confident with their dietary measures during sports. What was quite interesting is that more than 80% of patients said that the impact of GSD on the physical performance was either moderate or even high. We also asked for the emergency protocols and emergency management, and almost all patients had an emergency document at home that they also regularly used when they went to the hospital. But only 29% had a sick day regimen that they followed at home, for example, during episodes of fever, diarrhea, or vomiting. 17% reported that they did not have an appropriate emergency card. Alcohol is especially important topic for many adolescents with GSD1. And you all know that alcohol does not only do harm to the liver cell, but it also enhances hypoglycemias and is therefore especially harmful in patients with GSD1. When we asked for the information about the risk of alcohol consumption, 12% reported that they are not well informed about the risks, and 50% of patients said that they never consume alcohol at all. All other patients said that they regularly consume some alcoholic beverages, and these beverages included wine, beer, liquors, spirits, and also alcopops. You all know that traveling with GSD1 can be very challenging. But not surprisingly, all patients stated that they had traveled in the past, and the majority had really made good experiences. But 15% reported that they made rather negative experiences. Some of them said that the efforts that were associated with traveling were unproportionately high and outweigh the benefits. Some felt insecure with their dietary management during traveling. Some had hypoglycemias. And some said that, for example, if they went to certain activities, they could not take part due to their disease. Almost 90% of patients reported to have a driving license, but 2 patients with a driving license said that they usually did not drive on their own. We are not aware of any patients who have lost their driving license, for example, due to accidents caused in the frame of hypoglycemias. We also asked how patients communicate about their disease, and most patients reported that they openly communicate their disease with, for example, friends, sporting comrades, colleagues at work, or even superiors at work. And this is especially important as these persons can be important in managing emergencies in case of hypoglycemic events, for example. What was especially interesting for us was what attitude patients developed towards their disease in daily life. And we, for example, asked for the perceived severity of the disease. So patients were asked to rank the severity that they feel of their disease in a scale from 1 to 6. So from very severe to GSD is not a severe disease. And what you can see here are data for GSD1A patients on the left-hand side and data for GSD1B patients on the right-hand side. And what is kind of encouraging is that almost none of the patients said that GSD1 is a severe disease. And what you can also observe here is that there are no significant differences between patients with GSD1A and GSD1B, although from the external view, GSD1B is more often associated with a more severe disease course, including inflammatory bowel disease, infectious complications, and so on. We also asked how challenging the dietary management is for patients, and this seems to be very variable. As you can see here, about 1/3 of patients really think that management is rather difficult, while probably the majority says management of GSD is not that difficult. And this is the most encouraging picture. We asked, is a normal life possible with GSD1? And as you can see here, really almost all patients said that if certain measures are taken, of course you need a strict diet and you need monitoring and so on. But if these measures are taken, a normal life can be lived with GSD1. We also asked for emotions that patients feel in the association with their disease. And the most negative emotions, or the most frequently reported emotions that were associated with GSD1 were rage, fear, and anxiety. This is a very busy slide, but I will try to lead you through. We asked for the impact of GSD1 on different aspects of adult daily life, and the rather negative results are shown here. So as I have mentioned before, there are quite a lot of patients who say that the disease has a rather high or even or at least a moderate impact on their physical performance and fitness, which is not really surprising. But what I found surprising, especially in our German insurance system, is that a rather high number of about 30% reported that there's a certain financial burden associated with treatment costs, impact on professional education, and so on. So there's still a lot to do in the management of the disease. And the encouraging topics are that many patients report that their disease has only a low or a moderate impact on free time activities and sports and friendships, and also on partnership, but also on the intellectual performance of patients. And with this slide, I want to conclude. So our study has shown that really most adult GSD1A patients live an independent adult life and cope very well with their situation. And most patients had a rather positive attitude towards their disease, and they really felt able to live a normal life if certain measures are taken. But our study has also shown that there's still work to do, and it is really necessary that physicians that are involved in the care and in the transition of GSD patients should really start to support their patients in becoming autonomous as early as possible. And it is very important to address certain topics such as medical monitoring, also the risk of alcohol consumption, family planning, and so on with their patients during the transition process. I think that patient organizations are really a big help, and that the exchange with other patients, and especially with peers of the same age, may not only contribute to better information of patients, but really also provide emotional and psychosocial support that, for example, physicians cannot give. And with this, I would like to come to an end, and I really thank all participants of this study. I really thank the German Patient Organization for their really big support of our projects and for their open communication and the good cooperation. Thank you very much.